Okay, welcome to the Birmingham Medical News podcast. I'm Steve Spencer, the founder of the Birmingham Medical News. We've been publishing a monthly newspaper for doctors and all types of healthcare providers in Alabama now for 21 years. We also send out a digital version as well. So today's podcast, we do this in conjunction in partnership with Kassouf & Company. Kassouf & Company is a 100-year-old accounting firm here in Birmingham. And for our purposes, Kassouf has a really high-quality health consulting practice. Now, our sponsor of today's podcast is Carr, Riggs & Ingram. They're a CPA consulting firm with offices across the Southeast and into the Midwest. They have professionals who specialize in all aspects of healthcare: hospitals, nursing homes, physician practices, buying and selling healthcare entities, and of course tax and financial planning for providers. You can find out more about them at criadv.com. So, with that having been said, today we are going to talk about a minimally invasive endoscopic approach for skull-based conditions. And this sort of wrinkle here is the two doctors we have here do this with pediatrics, which is very unusual, as I understand it. Anyway, so we have to the left Jessica Grayson, who is a otolaryngologist, and to the right, James Johnston, MD, who is a pediatric neurosurgeon. Both of these physicians are with UAB and practice at Children's. Now, first thing I'd like to ask y'all is if you could tell us, I know there's a number of skull-based conditions. Might even tell us what a skull-based condition is. I mean, I can understand where it is, but give us some of the different various conditions.
I mean, you are the neurosurgeon.
Yeah. Well, so what's interesting about this area, and I think that's one of the reasons why this partnership is so important, is it's really the interface between the nose and the mouth, and then the base of the skull and the brain. And so there have been the introduction of both based on technology and different techniques to be able to access this area in a much safer and less invasive way compared to even 20 or 15 or 20 years ago. And so what we've been able to do is build a really powerful partnership based on Dr. Grayson's expertise with access to this area through the nose, and then my expertise with working with these conditions once you get inside the skull and with brain lesions. So,
and what are some of the various
conditions? So the main lesions that we tend to deal with is trauma. That it's a common area where there can be fractures at the base of the skull, and when you have injuries there, that can lead to leakage of spinal fluid, leading to meningitis down the road. The second major area, I think, is congenital lesions. Sometimes you can have defects in the base of the skull that can lead to where parts of the brain can actually come down into the nasal cavity, and those need to be fixed. And then the final main one is for certain types of brain tumors, which are located in the very base of the skull and are frankly very difficult to access through traditional neurosurgical techniques through the skull. But when Dr. Grayson's able to get access through the base of the skull and through the nose, are quite accessible.
Okay.
Yeah, no, I agree. Confirm. There are other areas of the skull base that we're not specifically talking about. There are interfaces with the ear, which are also a combination often of ENT and neurosurgery. It's just that's not what I do specifically. And so this is more in the anterior skull base that we're talking about. And this can be anything from, like Dr. Johnston said, trauma, which I know it's really sad to think about, but it is one of the number one issues facing children is trauma, whether that be car accident or otherwise. And benign lesions, which would be the things like when the brain kind of comes through a cavity that should have closed off during development but didn't. And those are called encephaloceles or meningoceles. And then other kind of quasi-benign things like pituitary lesions that are not cancerous, but they do have side effects and risks, so they're often managed that way, to malignant tumors that have to be removed and then treated afterwards with radiation or chemotherapy or some combination of. And in some cases, it's access to even biopsy something that we won't give the primary treatment for because it is chemotherapy. But the only way to get to it is either through the nose or through an open incision on the skull.
Okay. Well, would y'all explain the endoscopic procedure to us? I mean, from the moment you well, maybe I'm sure you probably do a lot of planning too. But if you would just explain everybody's role and how it works.
Yeah, so I'm like that annoying lady on the bus who's telling everybody with the megaphone, like, what's going on at the beginning. Because everything up to the brain interface is essentially sinus surgery, which is what I do almost every day. So that is still a camera in the nose, no cuts on the face, using tiny instruments that are meant to open up the sinus walls and kind of connect this space into one open floor plan. Once we hit the interface between brain and nose, a little bit like technique changes, the thought process changes, because now the anatomy is very different. And there's a lot more important things that live at that interface, depending on where you are. Obviously, the brain being very important, but optic nerves, carotid arteries, other nerves that supply function to the eye, the face. And so the kind of the planning really is about what we do when we get there. And that is a lot of discussion that's it's not always a formalized thing. Like, we're communicating when we're making those plans. Consistently as things come up, we talk about them, we think about them. You know, how are we going to get there? I feel largely when you're doing surgery like this, it's like, how do we fix whatever this problem is? And then what's the worst possible thing that could happen? And how do we prevent that? And that is kind of decides everything else. How do I repair the hole that I make? How long do I keep that person in the hospital? What do I restrict them from doing? How do I monitor this? What kind of antibiotics do they need? Do they need antibiotics? All of that's made based on really kind of like it's a risk assessment, although it doesn't happen in a formal checkbox, because it's kind of how we think about a lot of those things. I do think in the beginning, we spoke a lot about like every single step because we were getting to know each other and how we both functioned in that space. Now there's a lot of it that I think somebody could walk in the room and probably ask Dr. Johnston, what is Dr. Grayson going to want here? And he'd be like, oh, she only does this, this, and this. And whereas I can say, oh, I know he doesn't mind if the bed's this way. We can do it this way, whatever, just because we get used to working with each other.
Yeah, just like a group of musicians who've been playing forever.
Correct.
They know,
we've been working together since before COVID. And I think that a lot of that had to do with, Dr. Grayson's expertise in giving us, our approaches to these areas and really opening up our toolbox for my ability to access many of these lesions in the least invasive way possible. And then I think over time, as we become more comfortable with each other and more patients have been referred, doing more and more complex cases, I think that we become very comfortable with that planning process. The way that I think about it as the neurosurgeon is what is the access and what is the angle and how much do I need to see in the brain to do what I'm trying to do effectively. And then I can communicate that with Dr. Grayson, who can sort of decide what the best approach is, how much bone we're going to be able to remove, and the planning to be able to close things up afterwards. Because frankly, that's the biggest thing that's changed in this world, that has allowed us to do more extensive approaches because of Dr. Grayson's ability to close things up in a safe way.
And what would be an example of if you're doing more complex cases, of a really complex case?
I mean, I think I remember our hardest one was the transclival chordoma, echordosis maybe. The pathology wasn't clear. In a young person who had a cranial nerve that wasn't functioning. So one of the nerves that supplies the muscle, one of the muscles to the eye, had been compressed. And so that person could not turn their eye out, out laterally, and then also had double vision. And obviously, that can be problematic. Double vision can cause lots of little things like headaches, but also depth perception is off. People start favoring an eye. Depending on the age of the child, sometimes if you're really young, your brain can kind of ignore what the eye that's giving input that it doesn't recognize, it can ignore
and then
what
you
it's
end
doing.
up losing sight in that eye.
Correct.
Right? And how old was this patient, by the way?
And this was early teen years, so that wasn't really a risk. But it still can be very difficult if you're trying to like learn in school and you get a headache because you've got double vision. Yeah. And if you can't correct it with some kind of prism that the eye doctors or ophthalmologists can put in the glasses, then it's really a problem.
Now, was this somebody who had this problem their whole life, or did it?
No, it became a problem over a short period of time, but not like weeks. We're talking more like progressed over a few months.
Okay.
And on imaging, there was noted to be a mass in an area called the clivus, which is actually a bone that lives between the bottom of the sinuses and the top of the spine. Okay. And it looks like an ice cream cone.
Okay.
And it lives, that is like truly, really the interface between our two areas. It is like right over it is mucosa and muscle of the nasopharynx where the adenoids live.
Okay.
So still like very much in this ENT purview.
Yeah.
But the backside of it is the basilar artery and the brainstem, which is very much the world of neurosurgery.
Yeah. Wow.
And when you have masses that grow and replace a portion of that bone, they have a risk. One, it can compress backwards towards the brainstem and they can invade, and I say that kind of generically, not necessarily in a aggressively pathologic way, but can sometimes work their way through the dura, which is the lining of the brain.
Okay.
And then they can push on areas that where nerves are passing through that is very sensitive to compression. That particular cranial nerve that we were talking about is one of those that's very sensitive to compression because of its pathway and its size and its kind of caliber of the nerve. And so you can't always tell on imaging what these things are. Skull-based tumors are uncommon at baseline. Of all tumors that live in the world, it's like 1% of them of head and neck tumors. And then if you take that to children, it's really uncommon.
Okay.
So you can't even look at an MRI and go, we see these a million times every, in a year, and they're always this. It's not that clear. And so you often need tissue to confirm that, and especially in somebody like this who had a symptom. The other problem to that is that it's not like something on your skin where you go, I'll biopsy part of it. That wound is fine. It's safe. I can come back and do whatever's needed formally when I know the answer to that question. Because once you open this space, you've now potentially exposed, an artery, actually couple of different arteries. Carotid arteries live back there too. The brain fluid, that spinal fluid, which then increases the risk for meningitis. And so you have to have a diagnostic and therapeutic plan up front.
So I assume you must have obviously, when you talk about having a plan up front, you must have obviously with MRIs or some sort of imaging, you knew where you needed to go.
Correct.
You knew what the problem was.
Yeah, and we actually in the operating room, one of the technologies we use is a navigation system, so that basically when we're working, we can know where we're going, so that we can optimize the exposure, how much bone we're removing, so that when it does come time to open the dura or to remove an intracranial tumor, we're in a good position to do it, and we kind of already know where we are.
Yeah, and they actually fuse MRI and CT together, because there's a space where you want to bring CT to the forefront, and that's when you're with bony anatomy, because it's better for that. And then when you get to the things that are more soft tissue, so blood vessels, muscle, those kind of things, the MRI, and the brain itself, the MRI is way more helpful, and so you kind of push towards that portion of the viewing. But before, because we did this all inpatient, that person came in through the ER, and while they were in the hospital, Dr. Johnston got all of this imaging, and then we went over it together to say the potential of what this could be. Really, regardless, didn't change the approach to get an answer, but it was about having a plan depending on what we found and how we would manage that. And some important anatomy structures like being around the carotid artery. This conversation was everything down to like, what imaging tower do you want? What camera do you want? What day of the week should that be? You know, to make sure that you were doing it at a time that made sense, that you weren't pressured to be somewhere else, you know, and on some kind of time crunch. You know, what room do you do this in, with what team? We did this with a neurosurgical team in the operating room. And really, we go back and forth. Sometimes we're with an ENT team, sometimes we're with a neurosurgery team, just because they both live in that world.
But they both become comfortable with it because of, you know, how often we work together now. And you know, and so I do a lot of other brain tumor work that's through traditional, you know, craniotomies and other, transventricular endoscopy, et cetera. So I'm very comfortable with those techniques, and what's nice is to be able to work with Dr. Grayson in a way that I can transfer those same techniques from some of these other approaches, but now through the nose and the anterior skull base. And I think it results in better outcomes for the children, and allows us to provide these approaches that otherwise, you know, would not be available.
Yeah. When you say otherwise wouldn't be available, I mean you mean the endoscopic. Is that right? Okay.
Correct. Okay. Yeah, they would have to leave this area otherwise.
Oh, I see. I didn't catch that. Okay.
Yeah.
I see. In other words, you were the only ones
that are doing this. Okay. So there are 3 other people at UAB who are in my division, which is technically rhinology and anterior skull base. 3 of us are fellowship trained, but I'm the only one that goes to children's to do that. And there's no one else in the community. And wouldn't really probably be able to do that from an infrastructure standpoint. And there's no one at South Alabama that's doing that. I know they have a children's hospital, but there's not anybody down there doing that in the children's hospital on the ENT side. And there is no one in Huntsville either, which is kind of the other big spot where you can see that happen. So having the only standalone children's hospital kind of says that this is your only stop in Alabama, right? For a lot of things, not for everything, but for a lot of things. And so, I mean, I think some of this was born a little bit out of curiosity and interest on each of our parts individually, and probably for very different motivations, I would guess. And some of it a little out of like utility and having a heart for the people of Alabama and the kids of Alabama, and not wanting them to have to go somewhere else. Like, that doesn't work for your families that are helping take care of you, have other children. Right. And so it's something that matters to us for lots of reasons. We're both parents, so we you know, care very much about how that affects families. I think that even sometimes affects in a very positive way, like how we approach communicating and planning and how we take care of them, because we know what it feels like to be worried about our child. And that certainly allows us, I don't know, another way to connect with some of those parents.
For sure.
I know we're not probably the only people in medicine who have kids, clearly, but it is something you
it's definitely
it's
motivating
for
sure, for sure, yeah.
And if your child's ever had surgery, then you know what that feels like.
Big deal, yeah. And we're fortunate because, you know, with UAB and Children's of Alabama, you know, we have one of the, you know, most respected, experienced pediatric neurosurgery programs in the country. I mean, our fellowship program, we've trained, you know, half of our fellows are now currently directors of their divisions across the country. And then we're fortunate to have an outstanding ENT and rhinology program at UAB that's you know, nationally and world renowned. And so to be able to combine those 2 programs to provide this kind of a service, I think is important. And I'm really you know, really feel lucky that I get to work with Dr. Grayson on this.
I feel the same way.
Yeah.
And our hospitals are connected, which makes this even easier. Because if Children's was somewhere else,
it'd be harder,
then this becomes very difficult to do based on geography. So that's been really helpful. That was helpful a lot during COVID too. There was a lot of some back and forth of children and where they would go to have certain procedures while you're getting certain equipment, and sometimes children who are the victims of trauma are brought to UAB up front because that's where they go. But when it's determined their age, then that transition is made that they go to children's. But that's a very seamless process that has been utilized many times. And I think if we didn't have the proximity, we wouldn't have the benefit of that.
Yeah, we're lucky.
And so you started before COVID, right?
Yes.
Is that correct? And whose idea was, how did you guys get the idea that, hey, let's combine these and do endoscopic?
Well, I mean, I think at least speaking for our world in pediatric neurosurgery, it was becoming more and more again, there were only a few programs around the country that had anything like this, and even now there's not that many
When you
programs.
say anything like this, do you mean endoscopic?
A combined multidisciplinary, interskull-based
right.
program like this,
and a pediatric neurosurgeon specifically, because in a lot of places it's an adult neurosurgeon
working on children.
Mm-hmm.
Okay.
And they're not little tiny adults.
No,
of
very
course.
different. Very different.
And
yeah.
so it actually, there's a lot of that matters.
Yeah.
I mean, there's some great places in the country that do a great job, but I think it's probably difficult to switch your mindset sometimes if you go from treating an adult to treating a child.
Right.
And I think having the benefit of a stable force that is like always focused in that realm.
Yeah.
So you're always pediatric neurosurgery.
Yes. Yeah. I mean, I did my training in adult and then both, and then I did fellowship training in pediatric, but I do 100% pediatric now.
And, well, that's how prevalent. I mean, like how many cases come across? I wouldn't think that would be.
We do about 15 to 25 per year.
Okay.
So it's not a high volume compared to our other procedures that we do. But basically that's significant compared to most pediatric neurosurgery programs around the country.
Yeah.
Yeah, and that's been a growth over time. Like we've seen that since 2008 or 9 was when my senior partner joined UAB, and he did a few of these cases at Children's, although they were almost never a combined situation.
That's right.
That's what I'm talking about. The
Yeah, it
combined
was
situation.
usually the things that could largely live on the nose side, ENT sorted, and things that were largely on the brain side, neurosurgery sorted, and there wasn't as much opportunity for collaboration. And I think it was just a situation of like having a single person and how they navigate like that need time-wise when they have a whole practice at the adult hospital too. And so when I joined in 2019, that was easy. Like that was an easy addition to put there. And there was pediatric skull-based surgery as a part of my fellowship training.
Okay.
And so it was something I felt, super comfortable doing. The case that we did first really kind of landed a little bit in our lap. It was a situation of a congenital encephalocele, which so brain and the tissue or the lining around the brain kind of pooching into the nose in a space that would normally have kind of sealed off and separated during embryology when you're developing inside of your mom. And it had not, up to the point of 2, had not caused the child any issues. No one knew about it.
Okay.
And then there was a question of
So make
whether...
sure I understand. I shouldn't even ask this, but I just make sure I understand. So a little part of the brain had leaked into the...
to the nasal cavity.
Yeah. So when the whole neural tube is closing, which is what forms all of the portions of the you're gonna have to correct me because there's probably some of this.
I don't remember that stuff.
CNS system, so that goes from forebrain to the kind of lower brain portion in the spine. It's this little like base clef looking structure, and it has to separate and kind of pinch off and divide itself from places where you get other neural or neuroectodermal tissue, which is a big fancy way of like there are important things that live in our body that have a connection to nerves, like your sense of smell. That's neuroectodermal tissue in the nose, and it's supplied by the olfactory nerves, and they traverse this space between brain and nose.
Okay.
All right, but if you actually have a whole open tube, then anything can go pass through the tube. So those areas have to pinch off to prevent brain from being present in the nose. Or out on the skin, too, because you can get encephaloceles out on the skin as well. And there are some very common places where this has to pinch off and divide and bone has to form for these to be separated.
Okay.
One of those lives kind of towards the front of the nose and in the like anterior beak, so this area like right at the bridge of the nose behind your forehead, which is called the foramen cecum. And then the other place is at the hypopharyngeal canal, which is where the pituitary gland lives, right above the sphenoid sinus, which is the farthest back sinus. And in this particular kid, that posterior canal had not closed.
Okay.
And so brain tissue was pushing down, and children are not born with a sphenoid sinus that's open. There's no air in it when they're born. It's just a block of bone, and it aerates over the first 8 to 12 years of their life. So this thing that was sticking down was pushed all the way down where the adenoids live. So it looked like adenoid tissue. And the child had some nasal obstruction, which we see with large adenoids. And the child underwent a procedure by a different ENT to remove some of the adenoid tissue, thinking that was blocking their airway. Unfortunately, that's not what it was. It was an encephalocele.
And that was what was blocking the airway.
Correct.
Okay.
And so when that was noted, then...
So if the child hadn't have... Was the child really congested?
Yes.
Okay, so if it wouldn't have been for that, it might not have even been discovered.
Might not have been discovered for a long time.
Well, the problem with these encephaloceles is that if there is a connection between the brain and the nose, obviously the nose is not sterile.
Right.
And so if you get a connection between the spinal fluid, around the brain and the nose, which is, has a lot of bacteria, you can get meningitis.
Oh, boy.
Yeah.
So occasionally we'll actually have children with this who will present with meningitis.
Right.
They're older, it's never been not discovered. And then so the treatment for that is to treat the meningitis, and then we have to go in and repair it.
And repair that, okay.
I think that was actually how this kid ultimately presented to
people
us.
find out either, they're very congested and they think that that's, or meningitis.
Meningitis,
But I guess they're, okay, well, anyway, go ahead. I'm sorry.
Yeah. No, that's okay.
So the child came in.
So the child came in because that had been done and they actually got meningitis.
Oh,
right.
boy.
And so
That'd be
there was a
terrible.
question of what it came from. Nobody was
Yeah.
sure.
Yeah.
And they got imaging, as you do when you're treating meningitis. And on that imaging, it was discovered that there was a connection there between those two spaces. And neurosurgery was consulted, and you may have even been the person primarily admitted to because of the infection in this connection. And then ENT was looped in because of this question of adenoid tissue. And I think a little bit luck. I think the residents, ENT residents, knew that was something that I did and that I was available, and they asked, they're like, what do you think? And I was like, I could help do this. We could do this through the nose.
Okay.
We should talk to neurosurgery because there's not a great other way to get there.
To put in perspective, before these techniques, these transnasal techniques, the way that we would fix these is you would do a large incision over the top of the head, pull the scalp down, and actually do what's called a craniotomy, an opening in the bone here at the skull base, and then work from here, from above. And and you can imagine that's a little bit bigger surgery, and we'd have to take tissue to seal it off from above, and it's challenging.
Yeah, and then there's probably going to be a lot of swelling.
A lot of swelling, a lot harder on the children.
Yeah.
And then basically, when I met Dr. Grayson, and she was like, oh, well, we can just fix that. And I was like, it really sort of was like, oh, well, of course we can, but you have to have the expertise. She's kind of downplaying her expertise, but she did fellowship in Australia, doing some really high level, anterior skull base work in rhinology. And so when she came with the ability and the skill set to do this, it allowed us to do things we would not have been able to do in the future, in the past. So
that's perfect that you brought that up, because I was actually going to ask how you would have done it before.
Yeah.
Okay.
It would have been a lot of work because you have to kind of like sneak under, especially that space. Like you have to really get under the brain. That's hard.
Oh, it's very difficult. Yeah.
And I think the other thing because I posed this question to you on that case, in those particular encephaloceles, the problem is the pituitary gland is also involved and mixed in.
Okay.
And when you're fixing this, if you damage the pituitary gland, then you have made a 2-year-old child who now will have no spontaneous growth hormone production. Like you can hurt people if you don't think about that and look at those things. And so that was part of what we looked at, was like, where on here is the gland? Where do you see it maintaining contrast enhancement on MRI, making sure that we're safe so that this child continues to grow as normal and function as normal.
Yeah, by and large, it sounds like you need to know everything that's surrounding it, essentially.
Right. And I feel like we do a pretty. I'm never afraid to ask a question, even if it may sound stupid, just to be like, I just want to make sure, because the worst thing that you could do is assume that you know and never ask.
Yeah.
And in something like this, where every decision is really very important, although I feel like we move through a lot of them very quickly because we do it often. They're all very important, and the wrong one carries a heavy weight. And so we do a lot of double checking in, even in the middle of a case. You know, what do you think about this?
Yeah. I think the team approach really leads to much better outcomes because you can, discuss things and we work well together. And Jessica's not afraid to say, hey, I think that's not a good idea. Why are you doing that? And it lets me improve my treatment plan. And I think it's a very powerful teamwork.
Yeah, and I suppose because she's looking at it from a totally different perspective.
Yep, that's right. That's right.
Yeah, and we bring the experience of other things, because I might say, well, look, I've done this a couple of times in an adult, and here's what we did. Yeah. Is there any risk of that in doing that in a child? What do you think?
Yeah.
And we bring in other experiences.
Yeah.
We definitely call in, other opinions. We have the opportunity to have a multidisciplinary skull-based tumor board, which is with all of our other
with
ENT
UAB
and
adult
neurosurgery
skull-based,
colleagues.
exactly. Yeah, I think the thing about Dr. Grayson is that her day, she spends a lot of her time at UAB doing this kind of work for adult surgeries.
Okay.
So she's doing very complicated work with Dr. Kristen Riley, who's a UAB anterior skull-based specialist, and they do a lot of work together.
Okay.
And so she can bring that expertise for our cases, which are not as common as they are the adult cases, but she has that day-to-day expertise that really can be brought to bear on these more rare cases.
And you're pediatric, so you've got
exactly.
That. Yeah.
And the pediatric cases can be more challenging in some ways because the nose is smaller, the sinuses are smaller, the corridor that we work in can be a little bit smaller.
Yeah.
So when you do those approaches, you really have to be very, very accomplished with your general skill set to be able to do that. And like I said, I think we're very lucky that we have that ability.
And what with the pediatric folks with these skull-based conditions, what age range have you worked with?
6 weeks was
our
youngest.
Very young. Yeah.
And then all the way until they transition across 21. The street to UAB.
I'll be darned. See, I would have thought at 6 weeks you would just wait.
Well, that's a good question because the nose is very small at 6 weeks, which limits our abilities. But our 6-week-old we did was at one of these congenital encephaloceles. It was a large one.
Okay.
But it was in a place that was accessible.
Okay.
And I remember right that her nose was pretty good size. So it was
decent
bigger,
size. And it was causing so bad
issues,
congestion.
Yeah.
Okay.
And babies are obligate nasal breathers, meaning they have to be able to breathe through their nose to eat.
Oh.
Because they're constantly suckling on something for milk.
Yeah.
And if they can't breathe through their nose, then they actually can't eat effectively.
Good point. I can see that.
And so that child, even if one side of the nose is completely blocked, it can be very limiting. And that kid was not gaining weight on the trajectory that you would expect. And so, your ability to wait until 6 months becomes problematic.
Yeah, that enlightens me a lot because that was my first thought. As you said, normally the nose is much smaller, and obviously it's just going to be more difficult for a 6-week-old to go through surgery.
Yeah. Although I think she went home the next day.
Yeah, I think it's hard. I think it's harder for the parents.
Yeah, I was going to say.
I think it's harder for the parents.
But I just didn't think about the fact that babies
have to be able to breathe through their nose.
And so it would have been almost essential.
Yeah, it was essential. And plus the other risk is that if you wait, a child could develop meningitis.
Oh, yeah.
Because if there is that exposure.
Right.
So it's one of those things that typically when we find these things, we know we have to fix them.
And I will tell you, it seems more common in children. If children get meningitis, they run a higher risk of deafness.
Okay.
It can happen at any point, meningitis. It's very uncommon to hear about an adult who got meningitis and went deaf. But it's not wild to hear of a child gets meningitis and then they have deafness, and then you're looking at cochlear implantation, and you have to do that quickly before that cochlea ossifies, because it will do that in response to the inflammatory response of the meningitis.
Okay.
And if you're talking about a kid who doesn't yet speak, then you've now changed everything about the way they learn the verbal and heard audio component of language, and then language development for them, which they can obviously learn ASL and do those things. But that is also complicated when you're talking about a young child too. And so it's a lot of balancing risk and benefit, and can we get there? Can we do the right thing? Will it work? And we delayed to 6 weeks. We met the baby at 3 weeks. And it was like, well, if we can at least get you to 6, then like the nose is a little more open. And also you're a little outside that neonate grouping, and you just feel a little more comfortable kind of putting them under general anesthesia.
Do y'all ever see any of these later on in life just to see and just...
They all follow with me afterwards, long term.
Because I'd be curious if you see how they've done.
Yeah, so I get to see all of them because we follow up on how their sinuses heal around these areas. And often what I end up doing is when we've done a repair, if it's not a cancer or something we have to watch long term anyway, when we've had a repair that has healed and it's totally healed and I have no concern about that.
Yeah.
My role in their life afterwards is from a sinus function standpoint because I want to make sure that that's never the collateral damage of the access that we needed. And I see most of them at some point. We start seeing each other once a year.
Okay.
And I still see our first case.
That's what I was about to ask.
Yeah.
A little 6-week-old.
The first one was a 2-year-old. And I still see that child once a year. The 6-week-old I also still see.
That was just the youngest. Okay. Well, now, and curious, the 6-week-old was growing very slowly.
Correct.
Not able to go. Well, how did he or she turn out?
Total chunk, super, interact, very cute, very sweet, toddler. Now.
Just a toddler, so it's very recent. Okay. Okay. Not in the teen.
No, I get to keep up and see all the little milestones that they hit and kind of help navigate some of those with the parents, because then obviously like every cold that your child gets after they've had a surgery
Parents
like this,
worried.
you get a little nervous, and there's like not a way for you to know, and so there is a lot of communication back and forth, and I tell them always, like, I would rather you call and me be able to put you at ease, or say, hey, let me look and let me just make sure everything's okay, than you to be worried by something that we could easily answer the question for. And I think they know that. And all the trauma patients, like, they all end up seeing me, since the nose is the conduit for the pathway. We have to make sure it's all okay in the end.
Okay. Well, very, very, very interesting. Really, I've learned a lot. Is there anything I've missed that y'all want to add?
I'm trying to think. I don't know. I mean, I feel like it's been a nice growing process. We did do a 4-day skull-based course together a couple of years ago.
Where did y'all do that?
The University of Pittsburgh, which is kind of one of the homes of this work, these kind of techniques and whatnot. So,
which I thought that was great. It was a great experience. It was also we became very aware that most teams in most hospitals were not pediatric neurosurgeons. And
so it's very well now. All right, I know there's nobody else doing this in Alabama. If you're in, let's just say, let's say either Georgia or Mississippi, contiguous state, if a child has a situation, are they just going to have the adult team do it? Is that how it works?
Well, I mean, most places a little bit of a hybrid system in terms of where a lot of places there will be an adult skull-based neurosurgeon who works with an ENT, but there will be a pediatric neurosurgeon who will be sort of to help with patient care before and after and whatnot, and that's a good model too. I mean, there's different ways to do this, and even myself, if we have a case that's really challenging, that's really difficult, then I have no problems, talking to, Dr. Kristen Riley, who's one of my adult partners who does this, in adults all the time, to work together on those cases. I think there's no pride in any of these things. It's all about bringing the best expertise to bear for whatever the child's needs are. The good news is that most pediatric problems that we deal with are we feel very comfortable managing those things. But what's nice about being a big children's hospital and then a giant medical center like UAB is that we can draw on world-class expertise for things when we need it.
And because of the proximity, we can also the three of us can do cases. We can have my senior partner, Dr. Woodworth, and the four of us can do cases.
It's a really powerful model. I think that's one of the great things about it.
You've always got people you can call on.
The more people you have thinking about hard problems, I think the better you're prepared to manage.
No doubt about
absolutely.
it. I mean, I've experienced that too, because if you've got 4 people or 5 or 6 people.
Right.
One person there may have an idea that nobody else would have had.
Yep.
Correct. And different perspectives. And that's the benefit of that multidisciplinary group, because it also brings in neurosurgery folks who only do the lateral skull base.
Okay.
And they will bring, I say collegial challenges to our plan that we will, and they'll say, well, did you think about this?
Yeah.
Okay.
And they're totally outside of the box of what we're doing. And it's like, even if we're like, no, that's not a concern, but we have to defend that, in a way that makes you think about it. And you have to go, okay, why does that not matter?
Yeah.
And so I feel like you learn even more.
Well, when you have to defend something, you have to think through.
Right.
Yeah.
How did I come to this conclusion?
Right.
And
it gives you another little wrinkle. The next time that situation presents itself, I will think of that and answer that question before it comes to this space.
Yeah,
So.
and I've been doing this long enough to know that anytime you think something is real simple, that means you really haven't thought about it enough. So I think it's really important to take every case, go through the details and be challenged, and that's why I think the team approach is so powerful. Beyond just the technical aspects of it, I think the how you think through a case is really important.
Right.
So.
Yeah, it totally makes sense. Well, we want to thank y'all for doing this with us. Like
Appreciate
I said,
it. Thank you.
It's been interesting for me. I had not, I wasn't familiar with skull-based conditions at all before this, and I certainly didn't know you could do it endoscopically. So
Thank you for inviting us.
Yeah,
Absolutely.
appreciate it.
Enjoyed it. Yeah, I really appreciate it.
It's been great.
Yeah.
Awesome.
All right.
All right.
Thank you for listening to today's episode of the Ask the Doctor podcast, brought to you by the Birmingham Medical News and Kassouf & Company. Please make sure to like and subscribe, and make sure to tune in for our next installment. I'm Steve Spencer, and wish you and your loved ones a healthy journey until we see each other again.